32. 32 is a number of pills I used to count for my dad every single day after he was diagnosed with heart failure. I was only 12 years old when I watched the most important man in the world to me, the one who tucked me in every night with a smile, the one who taught me how to play golf, the one who always knew how to cheer me up, become nearly unrecognizable. As I watched him go in and out of intensive care units over the course of 8 months, I watched as his extremities grew swollen, he became increasingly short of breath, and he lost over 50 pounds. It's almost 15 years later, and not a day goes by I'm not incredibly thankful my dad is still here and healthy because of a life-saving heart transplant. His successful surgery was a gift that gave me and my family our most important person back. However, that gift came with a cost. While I didn't know it at the time, my family and I were experiencing a phenomenon called financial toxicity. Financial toxicity is defined as all of the negative impacts that healthcare costs can have on both patients and their families. For my family and for so many others, the surgery was really just the beginning. My father and my mother as his caretaker had to take over a year off of work, dealt with mounting medical bills, and ultimately made many sacrifices over the years in order to lift our family's financial burden. Some families are forced to take out high-interest loans, with some family members taking on second jobs, having children drop out of school, or even foregoing necessary expenses like nutritious food just so their family can make the next payment. For many patients and their families, financial toxicity can easily translate into a loss of childhood, frightening instability, and dreams deferred. My name is Jade Tso, and I'm happy to say that that little girl who used to sort pills for her dad is now a medical student right here at UC-Davis. Thank you. Where I've had the privilege of helping provide care to patients, many of whom are experiencing financial toxicity. I'm also a research collaborator at the program in global surgery and social change at Harvard Medical School, a member of the Surgeons Against Poverty Lab, and a fellow at the UC-Davis Center for Global Surgery. I study financial toxicity among cancer surgery patients in northern Thailand. And today I want to share with you what we've learned about why surgery can be so expensive, the far-reaching implications of financial toxicity after surgery, and what we can do to address it. Historically, surgical care has largely been reserved for people in the highest income groups, and even when lower income patients can access it, it often leaves them with lasting economic consequences. Building systems that ensure access to safe, timely, and affordable surgery for all patients is largely uncharted territory. To put this into context, if the whole world needed surgery today, 1 in 4 people would experience catastrophic health expenditure. That means that their out-of-pocket costs associated with the surgery would exceed 10% of their annual income or 40% of their capacity to pay. In other words, sometimes paying medical bills takes up so much of a patient's budget that they can't afford things like food, rent, or school fees. Every year, 80 million people experience catastrophic health expenditure. And in the United States alone, 1 in 5 people have medical debt. So if you or someone you know has experienced economic burden due to receiving life-saving medical care, know that this is a part of a larger systemic issue, and you're not alone. When a patient gets surgery, they experience 2 main types of costs: medical costs and non-medical costs. To better illustrate this, let's take, for example, Mr. Singh, who was a trauma surgery patient in India that my research team interviewed after he had a right leg major crush injury in a motor vehicle accident. He was uninsured at the time of his injury, so he had mounting medical bills that resulted in catastrophic expenditure. His family had to travel for hours to see him in the hospital, and he found it difficult going back and forth from his home to the medical center to attend all of his follow-up appointments. He spent 3 months recovering from his injury and took that time off of work, but he never fully regained functioning of his right leg. As a result, he was forced to leave his physically demanding job as an electrician and had to take a lower-paying, less physically demanding job. Let's examine Mr. Singh's costs a little bit further. First, he had medical costs. These are all of the costs associated with the surgery and the surgical hospitalization, like labs, testing, and imaging. Medical costs are significantly higher for patients who are uninsured or underinsured. In one study of a US national database of motor vehicle accidents, 92% of patients without insurance were at risk for catastrophic health expenditure, compared to only 10% of privately insured patients. However, even in settings with universal health coverage, where the government largely subsidizes medical costs, patients can still experience financial toxicity. In my team's work in northern Thailand, we have found that up to 44% of cancer patients undergoing surgery still experience financial toxicity. And we believe that this economic burden is largely due to the next type of cost: non-medical costs. Non-medical costs include anything related to the surgery that are not medical, things like food, lodging, transportation, and lost wages. So, because surgery is typically localized in major medical centers that tend to be in bigger cities, rural patients like Mr. Singh sometimes have to travel for hours in order to receive care. Similarly, my father had his heart transplant at a medical center 120 miles from our home. He couldn't physically withstand being able to, hours worth of travel multiple times a week, so he was forced to rent an apartment closer to the medical center so he could attend all of his follow-up appointments. Non-medical costs also include lost wages. Surgery requires recovery time, and depending on the type of surgery, this can mean days to weeks to months. My father was physically unable to work for 8 months prior to his heart transplant, and then was advised to wait at least 6 months while his surgical wounds healed. Not only are patients losing income during this time, but they're also more prone to job loss during the recovery period. And for some patients, like Mr. Singh, they might be physically unable to do the jobs that they did previously and have to go to lower paying roles. And this brings us to our next question. What are the broader implications of financial toxicity after surgery? First, financial toxicity can lead to worse health outcomes. In one study, financial toxicity made patients 2.6 times more likely to experience postoperative complications. Patients may also delay going to a medical center for fear of the cost. In the case of time-sensitive diseases like cancer, this delayed presentation and diagnosis can be deadly. Financial toxicity also makes patients less likely to attend their follow-up appointments, especially if they're worried about additional lost wages or transportation costs. Not only does financial toxicity affect the individual patient, but it can affect their family for generations. Mr. Singh's family had to take out high-interest loans in order to pay for their care, loans that it will take years for them to pay off. Mr. Singh's teenage son had to drop out of secondary school in order to work and help contribute to the family's finances. And their family had to delay Mr. Singh's mother's elective cancer surgery. Unfortunately, this is not a rare story. In one study done by the Surgeons Against Poverty Lab in a cohort of 850 trauma surgery patients, 36% of patients had to take out loans in order to pay for care. 10% of patients with children had those children drop out of school. No one should have to choose between surgery or survival, between financial ruin and healing. This is a global issue, and we need to employ systemic solutions that ensure access to safe, timely, and affordable surgery for all of our patients. And this requires a coordinated, multifaceted approach across several levels of the healthcare system. And this brings us to our final question. What can we do to address financial toxicity after surgery? First, we can reduce out-of-pocket medical costs for patients. For instance, we can implement the Choosing Wisely initiative, which is a campaign that was spearheaded by the American Board of Internal Medicine. Doctors can promote only cost-effective tests and treatments that provide tangible value to patients, preventing unnecessary expenses. However, sometimes patients like my father and Mr. Singh require life-saving surgery, so we can't avoid this expense. At the time of their surgeries, both Mr. Singh and my father were both uninsured or underinsured. We know that patients who are uninsured face significantly higher financial risk than patients who do have coverage. Similarly, countries that have universal health coverage tend to have much lower rates of financial toxicity than countries without. However, even in settings without universal health coverage, publicly available insurance programs still exist. However, many patients remain unaware of their eligibility or their benefits. In a study conducted by my team, a cohort of trauma surgery patients in India identified key barriers to insurance. This included limited awareness of its importance, available insurance plans, coverage details, and difficulty in accessing insurance if they did have coverage. By empowering patients to better understand their eligibility and their benefits, and by connecting them to publicly available insurance, we can reduce out-of-pocket medical costs for patients. Insurance literacy programs led by social workers on a health facility level can help bridge this gap. For low and middle income patients who maybe cannot afford private plans or they don't qualify for publicly available insurance, microhealth insurance presents a viable alternative. Microhealth insurance is a community-based financing model where pooled resources can help cover medical costs for patients, particularly benefiting those who don't have savings. Studies have shown that microhealth insurance beneficiaries spend up to or borrow 30 to 34% less, spend up to 74% less of their savings, and are less likely to sell assets to cover their healthcare costs. However, sometimes insurance is not enough to always stave off toxic financial effects, and non-medical costs can still push patients into financial burden. Let's take, for instance, Ms. Krungtap, who is a university student in northern Thailand, which is the setting of universal health coverage. She had a surgery to remove a tumor from her right breast, and her grandmother is her main caretaker and the household's sole income provider. Traveling long distances for care means lost wages, transportation costs, and lodging costs for Ms. Krungtap and her grandmother, and they think it may take years in order for them to pay some of their bills off. We can reduce non-medical costs for patients like Ms. Krungtap and her grandmother. Strategies such as food and travel vouchers can help reduce costs for patients who have to travel long distances for care. Studies have shown that food vouchers can reduce hospital readmissions, while travel vouchers can significantly improve follow-up care access. Existing government food assistance programs like India's public distribution system or the United States SNAP and WIC program can be leveraged in order to support surgical patients during both their treatment and the recovery periods. Social needs assessments like food insecurity screening can be a vital first step in connecting patients to these existing resources. In my team's work in northern Thailand, our patients have also suggested expanding telemedicine, as well as scheduling multiple appointments on the same day in order to reduce travel costs for patients. And this is a simple logistical solution. Scheduling multiple specialty appointments on the same day can help save patients like Ms. Krungtap and her grandmother the equivalent of days of lost wages. Lastly, we can address lost wages for patients. Strengthening public unemployment and disability support programs can help prevent economic catastrophe for patients when they have prolonged recovery times or permanent disability after surgery. In Germany, at-risk patients participate in work-related medical rehabilitation programs, and unemployment risk screening tools can be used in order to identify patients for work reintegration programs. Additionally, programs that offset lost wages can help reduce financial burden for patients facing urgent surgery-related expenses. For instance, community microfinancing programs provide loans to low-income patients who otherwise wouldn't have access to traditional financial services, providing a financial lifeline when they need it most. When I think about all of these potential solutions, I can't help but think of how they might have benefited so many of the patients that I've met. Knowledge and access to insurance programs could have prevented Mr. Singh from having to take out high-interest loans that will take his family years to pay off. Would expanding the use of telemedicine have prevented my family from having to rent a second apartment closer to the medical center, rent when neither of my parents had the capacity to work and they had 2 young children to budget for? Would scheduling multiple specialty appointments on the same day or travel vouchers have eased some of the extreme stress that Ms. Krungtap and her grandmother were facing? When Ms. Krungtap, a university student balancing schoolwork and cancer treatment, should really just be focused on healing? Would connecting Mr. Singh to community microfinancing programs or work reintegration programs have prevented his teenage son from having to drop out of school? I think of all of the psychological distress, personal sacrifices, and dreams deferred that might have been avoided. Our goal should be to create a healthcare system where no one faces significant financial burden because they access necessary life-saving surgical care. The journey towards that goal starts with putting patients, especially the most vulnerable, at the center of our efforts. By embracing and implementing these solutions, we can hopefully create a future where everyone, regardless of income or background, has access to safe, timely, and affordable surgery. Thank you.